Good evening. This is Dr. John Bennett, broadcasting another in a series of Parkinsonism education hangouts with Dr. Abdul Rana, a neurologist from Toronto, Canada, and world-renowned Parkinsonism educator. Tonight, Dr. Rana is going to cover essential tremor, a condition mimicking Parkinsonism. Good evening, Dr. Rana.
Good evening, Dr. Bennett.
How are you tonight? You're looking fit as a fiddle. Okay, let's start with off of the questions. What can mimic Parkinson's?
The diagnosis of Parkinson's in most cases could be quite straightforward and relatively easy when patients have typical symptoms. However, in some cases, it could be a challenge. When the symptoms are not very typical, or patients have other history of other conditions or some other factors which may make you think that there could be some other condition, and some of the conditions could mimic the diagnosis of Parkinson's disease. And some of these include essential tremor and some other tremor syndromes, and atypical Parkinsonism such as progressive supranuclear palsy, multiple system atrophy, corticobasal degeneration, vascular and drug-induced Parkinsonism, Lewy body disease, normal pressure hydrocephalus, and Wilson disease. So these conditions could be kept in mind when things are not straightforward and patients don't have a typical presentation. So one should go in their mind one by one to see if they are not missing any of these conditions, or any of these conditions not overlapping.
And occasionally use dopamine to diagnose the Parkinsonism, correct?
Not to diagnose, but if patients have a response to levodopa, so that reassures the treating physician that the diagnosis is correct.
Okay. Okay, how can essential tremor be mistaken for Parkinsonism?
Essential tremor, although, is a condition which is more on action, such as when patients are writing, or if they are holding cups full of liquids, or they're eating with spoon and fork, they spill, so they may have difficulty putting makeup. So this is the common presentation of essential tremor, and essential tremor is much more common than Parkinson's disease, and sometimes it could become a problem. The essential tremor, although is bilateral, the symptoms of Parkinson's disease usually start on one side, or they are more prominent on one side. And on the other hand, the essential tremor could be asymmetrical in some cases. So in some patients, the essential tremor, severe or moderate, or even sometimes mild essential tremor, could be accompanied by a very subtle resting tremor. So that makes you think that this could be Parkinson's. So that resting tremor could be due to incomplete muscle relaxation. Therefore, when we are not sure, we ask patients to lie down. They should be in a complete rest and repose before you can conclude that it is a purely resting tremor. And elderly individual, they could have mild cogwheeling, especially at elbows. So that cogwheeling with a slight resting tremor, although they have essential tremor, so that could again be confusing. In some patients who are elderly, they could have age-related slowness, or if they have arthritis, if they have pain, or if they're slow otherwise. So these things could cause some difficulty in the presence of essential tremor to come to a more certain diagnosis of Parkinson's disease. There are certain other types of tremor, such as a drug-induced tremor. So drug-induced tremor is usually on both sides of the body, It could be asymmetrical. Patients have more than one type of tremor. They could have a resting tremor. They could have a postural or kinetic tremor with it. And some other tremors, such as a cerebellar outflow tremor or cortical tremor, or a tardive and a neuropathic tremor, or some cases, a post-traumatic or enhanced physiological tremor. So all these types of tremor could make you think that there is some overlap with Parkinson's disease, and a person should be quite careful when they consider the diagnosis of Parkinson's disease, that they should keep all these different types of tremor in their mind.
What are the main features of the essential tremor?
The essential tremor is usually a tremor which is present with action. That is the most important feature. And patients, as I just said, they complain of writing, holding cups full of liquids, or eating with spoon and fork. The essential tremor is usually bilateral as compared to Parkinson's disease, although it could be asymmetrical, and then it has bimodal presentation. Sometime in 50s or 60s, it could become a problem, or it could become first time apparent, or in some cases, in patients may have in 20s the essential tremor, and they might complain of difficulty writing. Their handwriting has become messy. They might have difficulty when they're pouring liquids or when they're shaving and they're doing any fine movements, such as using a screwdriver. So they might feel embarrassed in social situations in cases, and they may stop going out. In some cases, it's more noticeable when they're signing the checks. So at that time, their hand could go like this. And when you examine these patients would have a tremor when they outstretch their arms, or when they're holding a cup. You tell them to hold a cup and bring to their lips and go back so you can assess. And on finger, nose, finger testing. And sometimes these patients have a family history of similar tremor. And actually, family history could be a lot of times if you take extended family history. So it could be found in first degree or second degree relatives much more frequently than Parkinson's disease. And another feature which can help, that sometimes, although not in all cases, the tremor may be dampened shortly with alcohol intake, the essential tremor. And in case of the children, the boys have more tendency somehow to have essential tremor than girls. And patients usually don't seek attention when the essential tremor is mild as compared to Parkinson's, because essential tremor causes trouble mostly with writing or holding things, but patients don't feel slow, they don't have drooling, or they don't have other loss of sense of smell or frozen shoulder, so they may not seek medical attention as compared to Parkinson's disease, that patients with Parkinson's disease could seek medical attention early on. In case of essential tremor, when they start noticing some disability in doing their tasks, then they would talk to their physician, and they get referred to a neurologist if needed. So the essential tremor could cause a social phobia, but they might have subtle other symptoms as well, which usually go ignored. They might have subclinical deficits in visual perception, encoding, fluency, and working memory. And but these things usually cannot be concluded based on a screening neurological examination. And these patients may require a detailed neuropsych testing to look at those subtle deficits. With respect to the subtle essential tremor, when it's mild, so you can do some mental tasking, like you can stress patients by doing serial sevens backwards, or reciting months in reverse. That would help to make it more prominent. The essential tremor, like most other movement disorders, it would also disappear during sleep. And somehow, some patients notice a very coarse tremor in the morning when they wake up. So for a short time, they feel their tremor becomes very obvious or coarse, but by noontime, it could start improving again.
Okay. What parts of the body are most affected with essential tremor?
The essential tremor mostly affects the upper extremities, the hands, and it's a flexion extension type of tremor. It means that the movement is this way, rather than Parkinson's patients which have this way movement, supination, pronation. However, in some cases of Parkinson's, they could have a flexion extension tremor as well, although in a minority of patients. And the size of handwriting as compared to Parkinson's patients. In Parkinson's patients, the handwriting becomes small. When they sign check or they write, their handwriting is much smaller than normal, or sometimes if they write a sentence. So they may start okay, but by the time they end, their handwriting becomes quite small. If you compare the first letter with the last word, so the first word and the last word, they are quite different. So it goes like this. So in case of essential tremor, the handwriting is actually, it may be large. It may be large and it may be more messy. And when you ask these patients to draw a spiral, you can notice the tremor very obvious on the spiral drawing. Otherwise, the essential tremor could involve head, whereas Parkinson's tremor usually does not involve head, and voice also. The essential tremor involves voice, and the Parkinson's tremor usually does not involve voice, and essential tremor could also involve tongue. Legs and trunk are also affected, but they are affected in the later stages and very infrequently. The tremor, in case of essential tremor, is usually a medium frequency, anywhere between 7, 8, or up to 10, and the amplitude is variable on the degree of tremor, but as compared to Parkinson's, the Parkinson's tremor is a low frequency tremor. It's about 5 hertz, 3 to 5 hertz. The frequency of essential tremor could decrease with time because the amplitude is increasing, so the frequency may decrease with time as the tremor increases in the amplitude. And some patients with essential tremor, they could find difficulty with tandem gait. When you ask them to do tandem gait, heel knee testing, what most patients laugh and they call, sobriety testing. So they may have difficulty to do the tandem gait, and sometimes their gait could be a bit wide-based, and you may have difficulty to differentiate from the cerebellar disease. So otherwise, their examination is usually normal. The women somehow they have higher tendency to have head tremor in some reports, and if the tremor is only unilateral, so it could be dystonic, a focal dystonia, or it could be a primary writing tremor. Usually, essential tremor is not purely asymmetrical, like purely unilateral. It could be asymmetrical. And sometimes, in advanced cases of essential tremor, you may see a crescendo-ascendo pattern when it reaches the target, which is usually a feature of cerebellar intention tremor. But in advanced essential tremor, you could see a subtle tendency of this. Indeed, the essential tremor is not just a tremor, it's a syndrome. Most experts believe it's a syndrome, and most patients would exhibit a monosymptomatic type of tremor. Either they will have a hand tremor or they have a head tremor. So, and it stays like this most of the time, but if you assess carefully, you may notice some tremor in their tongue or in their voice. The jaw tremor is another thing which you can see in patients with essential tremor, but the jaw tremor could occur in patients with Parkinson's disease as well. So just based on jaw tremor, it's quite difficult to make a diagnosis or reach a conclusion that it's essential tremor. So you have to look at other features, if they have rigidity or bradykinesia, or if they have in the jaw tremor, they might have head tremor and voice tremor, which is more prevalent when patients have jaw tremor. So you have to look at all the features to put the whole picture together. The tongue of these patients could be examined when it's resting in mouth and on a partial protrusion. So when you ask these patients to protrude their tongue partially, so you can see a tremor very, very easily. The facial tremor is another thing. Sometimes these patients have bilateral facial tremor. When you ask them to do a half-hearted smile, so their face will go like this on both sides. You can see that. And I had one patient who had this facial tremor, and it used to dampen typically after the alcohol intake. When he would drink alcohol, his facial tremor would disappear, but otherwise he would have this. It was quite embarrassing for him because whenever he would try to smile, his face would start going like twitchy. In the voice tremor, you can check with the phonation. If you ask patient to say it's sustained, like E, like they should breathe in and then hold a note, a prolonged note, then you can see in the sustained phonation that it's obviously audible. Then sometimes you can assess if they are adding breaks in the phonation when they go like this, E, so it would be like this. In some cases, the central tremor could be obvious when it's severe. It could be obvious when they're talking.
What can help in the diagnosis of essential tremor?
The history of having a bilateral, postural, and kinetic tremor of both hands is usually helpful. And then there should be absence of other condition like endocrine condition, metabolic condition, drug abuse, or features of dystonia, cerebellar tremor, and hyperthyroidism, anxiety, peripheral polyneuropathy, or alcoholism, because these conditions could be associated with a tremor. So they should be kept in mind that patients should not have these conditions which are causing the tremor. And the essential tremor may affect only one body part at times, just the hands. In some cases, just the voice, tongue, hands, or head tremor. The tongue tremor could interfere with speaking as well as eating. Most experts these days are of the opinion that what we used to call isolated head tremor, that could be more of a dystonic tremor, which was in some cases neglected as a isolated head tremor. So these findings could help in the diagnosis of these patients. And then some patients could have a chin tremor, which in some cases could be familial autosomal dominant. The lip tremor usually does not happen in essential tremor and is seen in cases of Parkinson's. The tremor with the trunk is quite rare. The truncal tremor in essential tremor is not very common. One thing which could help the patients who have tremor of upper extremities, so if they have a slight resting component, or if you are unsure that there could be subtle features of Parkinsonism, then you ask them to outstretch their arms. So they might have a latency. If they have Parkinson's disease, they might have a latency of several seconds before the tremor would come out. But in case of essential tremor, the tremor is quite apparent right afterwards. The association between essential tremor and Parkinson's disease is quite controversial in literature. So there are opinions both ways. So I'm still a student of movement disorder and studying this field. So as I said before, the main features are bilateral postural and kinetic tremor, sometimes isolated head tremor, and absence of other conditions such as a neurological head trauma, metabolic condition, thyroid condition, or a sudden or stepwise progression, enhanced physiological tremor, or sometimes a orthostatic tremor, that patients have a tremor when they stand, their legs go like this, and then when they start walking, it disappears. So also position-specific or task-specific tremors, they could be ruled out in these patients as well, which are usually on one side of the body.
Okay, very good. Anything else to add to the difference between essential tremors and Parkinsonism before we close?
You always ask me to add something at the end.
well, no, you don't have to. Is there something that you want to add? It's okay. We can end it.
With respect to Parkinson's disease and essential tremor, okay, it may not be as easy sometimes as it sounds to differentiate. Yeah. In elderly patients, so it could be a challenge. And when essential tremor becomes worse, so then it could have a resting component. Patients may be slow due to age. So I find it a little bit difficult at that stage. And some patients may not be good historians. So anything you ask them, they would say yes to most of the questions, and then you get confused. So it's not a very straightforward diagnosis in all cases, although most of the time you don't have much difficulty making a diagnosis of essential tremor. So, but it's a quite interesting field.
Very good. Okay, that covers it for essential tremor, a condition that mimicking Parkinson's. This is another in the series of hangouts for Parkinsonism education. Thank you, Dr. Rana.
Thank you, Dr. Bennett.
And thank you. All these videos can be seen at parkinsonism.tv. And good night, Dr. Rana.
Good night.
Good night. See you next time.
See you later.